Hello everyone. Today I will talk about one size doesn't fit all. Anesthesia challenges in syndromic congenital heart disease. Myself, Dr. Jigisha Pujara, professor in cardiac anesthesia at UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Congenital heart disease and syndromic management, a high-yield guide of a perioperative care, physiology and risk stratification. The dual challenges, one is physiology as for the congenital heart disease condition and versus the anatomy of the syndrome. Hemodynamic challenges, congenital heart disease is incidence is 8 to 10 per 1000 live births. Risk hemodynamic instability and cardiac arrest. Risk is about 0.79%. While the anatomical challenges are syndromic airways, key highlight insight is the improved survival, means these patients now present frequently for the non-cardiac surgery as well as the cardiac surgery. Mastering the CHD physiology, the three types of the circulation, series circulation, parallel circulation and the single ventricle physiology. Series circulation is anatomically is a normal or corrected condition, like in the ASD, small to moderate size of the VSD, etc. Here the flow is systemic and pulmonary in the series, while in the parallel or balanced circulation the anatomy mixing is there, like in the condition of the TGA, large VSD with Eisenmenger syndrome like condition, risk of QP-QS mismatch is there, and the high pulmonary blood flow causes the edema, and if there is a low pulmonary blood flow will cause the cyanosis. Single ventricle physiology, there is anatomically patient may be posted for this Fontan or hypoplastic left heart syndrome. Risk is a passive pulmonary flow and the highly sensitive to the intrathoracic pressure, that is a positive pulmonary ventilation. So positive ventilation is highly affecting this type of the physiology. The landscape of the defect classification dictates the physiology, either right to left shunt or the left to right shunt. Right to left shunt means there is a decrease in the pulmonary flow, and the conditions like the tetralogy of Fallot, pulmonary atresia, tricuspid atresia, etc. While in the left to right shunt there is an increase in the pulmonary blood flow, the conditions like VSD, ASD, AVSD, PDA, etc. And mixing complex cases where there is a mixing of the blood, these are the TGA, truncus arteriosus, TAPVC, etc. Some obstructive lesions like coarctation of the aorta and aortic stenosis are also there in congenital disease with syndrome. Mastering the physiology, the balance between the SVR and PVR is important. Systemic vascular resistance, SVR, ketamine causes the maintains the SVR, and propofol will reduce the SVR. So propofol while giving is a very sensitive, and you have to be very careful while using the propofol. Usually not much used. While a pulmonary vascular resistance balance is hypoxia or acidosis causes the increase in the PVR, while high FiO2 and nitric oxide will reduces the PVR. And target flow ratio QP by QS should be 1:1. And single ventricle physio protocol targets the SpO2 here is required 75 to 85% to prevent the pulmonary overcirculation. The hemodynamic balancing act, there is a induction agents like opioid, high stability, blunt the stress response, maintain the SVR. Ketamine preserves the SVR, good for the PHT, pulmonary hypertensive patients. Propofol, caution, vasodilatation, decrease the SVR, and when there is a right to left shunt, there is an increased shunt portion. So be careful while using the propofol, particularly in the right to left shunt. And balancing act of the PVR by the ventilation strategy, hypoxia, hypercarbia, increase PVR, bad for the right heart, and hyperoxia or the hypocarbia decreases the PVR, risk of pulmonary flooding in parallel circulation. Post-operative critical care, the big three, there are three issues major in the perioperative post-operative phase. Low cardiac output, there is a single when there is a low cardiac output, the signs and symptoms are the oliguria, acidosis, cold peripheries, Management may require inotropes, milrinone or dobutamine like inodilators may require, and optimization of the preload. PAH crisis, pulmonary artery hypertension crisis, trigger the by the agitation, pain, hypoxia, etc. And management hyperventilation with alkalinization of the pH more than 7.45 or nitric oxide, and some inodilators also helpful like milrinone. Another is arrhythmia, particularly the JET, junctional ectopic tachycardia. The context post VSD top repair. These are the main conditions which causes the JET commonest. Management will be the cooling of the temperature up to 34 degree. May require sometime pacing, amiodarone, and reduce the anotropic agent, in deeper plane of anesthesia, reduce the anotropic like drugs like arrhythmogenic drugs like adrenaline, etc. is required for this management. The perioperative audit red flag checklist. Respiratory, one is the first is the respiratory. Here the recent URTI or fever, if possible, that case can be postponed, and the CRP WBC has to be checked. And if elevated, we cannot go for proceed. We have to treat it first, and then we can proceed. Cardiac reserve, sweating, tachycardia, hepatomegaly, etc. can be there. And here implication sensitive to the vasodilators. So vasodilators may required in a perioperative case in such type of the conditions. Another is a hematological hemoglobin. If more than 18 gram percentage, that is a polycythemia. There is a hyperviscosity syndrome. So in a cyanotic congenital heart disease, when there is a polycythemia, the risk of the coagulopathy is high. And big trap is dehydration trap. Cyanotic patients must not be dehydrated. NPO as per the ERAS guideline, clear fluid up to 2 hours, and pre-induction tidal volume 2 ml per kg. In pre-induction intravenous 2 ml per kg volume can be given. Intraoperative architecture, induction of the to the excess. So induction strategy, fentanyl, ketamine, avoid the propofol is fine. The fast track shift, lower the opioid doses, so a patient can be fast track management. Extubation can be planned early. Neuromuscular blockage also similar. We have to use for the considering in the mindset of the fast tracking, Caesar trachurium or rocuronium. Access and the monitoring, if is for the age and weight of the patient, central venous catheter placement, and the monitoring of the CVP, and the arterial cannulation with the arterial line as per the radial or femoral as per the age and weight of the baby. And requirement of the nowadays there is a requirement of the NIRS cerebral oximetry and the transesophageal echocardiography. These are the monitoring required in this type of the patients. The bypass and the aftermath. As you all know, CPB is a patient has to be hematocrit maintained at 21 to 24 degrees centigrade, cooling up to 32 to 34 degree, 32 to 15 degrees centigrade, as per the condition of the patient. Some patient may require the deep hypothermic arrest, some patient may require the mild to moderate cooling. Ultimately, arrest of the heart has been done, surgery has been done, and rewarming once surgery is done, 36 degrees centigrade up to rewarming, and then weaning. This is the cycle of the CPB. As you know, what are the problems? Increase in the PAH causes the RV, increase in the RV afterload. It will causes ultimately, eventually, LV preload reduction and a low cardiac output syndrome. And again, these again lead to the PH. So there is a vicious cycle of pulmonary artery hypertension. We have to break this cycle by some management modalities like the hyperventilation, alkalinization of the pH more than 7.45, nitric oxide, milrinone, etc. The syndromic challenges now is we coming to the syndromic challenges. Multi-system impact is there. We are most worried of the airway first, because intubation is the priority of any cardiac surgery. So airway anomalies like micrognathia or macroglossia, these are the condition of the airway may involve in the many of the syndromic child. There is a cardiac lesions, or there may be the cardiomyopathy in some lesions. Hematological coagulopathy, either patient is having the hyperviscosity syndrome due to the polycythemia, and there is eventually the coagulopathy also there. C-spine, cervical spine instability, or the fusion. Some condition having the cervical spine fusion and some having the instability. So we have to be careful regarding all these conditions, and of course the metabolic conditions like hypoglycemia, calcium abnormalities, etc. can be there with the syndromic child. 10 to 15% of the CHD patients require intervention for extra cardiac anomalies as well. For airway assessment, there is a Cooper score. The syndromic airway prediction and assessment by this Cooper score. C stands for the micrognathia or the retrognathia check, and opening the O stands for the opening interdental distance. P for a previous history of difficult intubation or the obstructive sleep apnea syndrome. U stands for uvula visibility, like in the Malampati equivalent, and R is a range neck extension and the motion of the neck. So flexibility of the neck and stiffness of the neck has to be checked preoperatively. This is the checklist for the airway assessment of the syndromic child. So Cooper scale. Risk state difficult laryngoscopy 1.35% in the general pediatric patients, while significantly higher in the syndromic children, when many times we can not able to intubate the children also. Golden rule: verify the face mask ventilation capability before administering the paralyzing agent. Syndrome spotlight. Trisomy 21 is a Down syndrome. Here patient is having typical features of the macroglosia and the microdontia. Macroglosia, large tongue, and microdontia and atlantoaxial instability may be there. Laxity of the transverse ligament. So avoid extreme flexion and extreme extension of the baby while intubation. Subglottic stenosis is usually there, so use the AT size 0.5 to 1 size smaller than the usual required as per the weight and age of the baby. CHD incidence 40 to 50%. This is AVSD, most common. Risk of the bradycardia on the induction. So be careful while inducing this type of the patient. Other risk factor concerned to the anesthetics are the hypotonia. Patient is having so much hypotonia. Post-operatively, to control the patient and avoid the fall of the baby from the bed, has to be we should be very careful because of the hypotonia, the extreme flexibility, and they are hypermobile children. And another issue with us is the difficulty of the IV access and difficulty in the arterial cannulation. This laxity of the loose areolar tissue will lead to the difficult IV access and the arterial cannulation, and there are a number of alveoli are also less and number of bronchi also less. So these children we have to accept low PO2 in the perioperative period. These are the specific features of the Down syndrome. Typical feature of the Down syndrome, note the macroglosia and the wide epicanthal and trisomy 18 and 13. Trisomy 13 is a Patayo syndrome and trisomy 18 is a Edwards syndrome. Here a baby, photo of 3-month-old infant with the trisomy 18, Edwards syndrome. Note the microphthalmia and the micrognathia, short neck, and there is a failure to thrive baby, and the infant was also hypotonic with the club foot also. This patient had ventricular and atrial septal defects. Craniofacial anomalies like the difficult airway cluster. There are 3 types of the craniofacial anomalies where the difficult airway clusters can be observed. First is the Pierre-Robin syndrome. Here the triad of micrognathia, glossoptosis, and the cleft palate can be there. Color obstruction, or course is the obstruction often improves with the age and management. These patients are prone for positioning. Nasopharyngeal airway should be required. Treacher-Collins syndrome feature maxillary or mandibular hypoplasia, conal atresia, causes airway difficulty and worsen with the age. Management of required is the LMA often effective if we cannot intubate the patient. So failure of intubation should be considered in the mind. Golden heart syndrome features are hemifacial microsomia and tracheal deviation. Management asymmetry makes mask ventilation difficult, so one should be careful for the various strategy to manage the mask ventilation. Here is a Turner syndrome. Usually Turner syndrome is found in the female child with the absence or the deficiency of the one or total absence of the X chromosome. Here typical feature is there is patient is having the premature infertility and ovarian failure, and typical features as shown in this picture is the web neck, low hairline, and cardiovascular conditions usually with these. Golden heart syndrome in a 7-year-old male, not the facial asymmetry with the hypoplastic mandible and ear deformity on the left ear. This is the 12-year-old boy with the Hurler syndrome and corneal opacity who presented for the ophthalmologic surgery. Patient is having, you can see that cataract like condition, and patient posted for ophthalmic surgery with the typical phenotype: short stature, coarse facial features with the mucopolysaccharide deposition in the lips, tongue, epiglottis, tonsil, adenoids, and short neck with the low set ears, short fingers with the joint stiffness. You can see in the figure D, there are fingers are short and the stiffness of the fingers also there. And patient can have the enlarged liver and spleen with an umbilical hernia. Here you can see huge abdomen with umbilical hernia. And Hallux valgus, there's a author has commented this: for this child intubation, laryngoscopy and mask ventilation was difficult, intubation was not possible, so manage patient with the mask ventilation only. Structural and metabolic challenges: mucopolysaccharide, Hurler or Hunter syndrome. Pathology, there is a gag deposits in the tissues and airway, stiff neck, thickened tissue. Risk of the complete obstruction can be there. And Bequeath Wiedemann disease. Here pathology is overgrowth syndrome. Airway is severely macroglycia. Metabolic conditions like profound hypoglycemia risk is there in this type of the patients. Another is the apart syndrome. Here the pathology is the there is a craniosynostosis, and patient airway is problematic here. Mid-phase hypoplasia and fused trachea, tracheal rings. So bamboo trachea is there here. So flexibility of the trachea is not there. Injury to the trachea can be there. Intubation can be difficult in such type of the cases. Klippel-Feil syndrome. Here the pathology is the fused cervical vertebra. So short problem is the airway, short neck, and impossible extension. So we have to keep the boogie ready in such type of the patients when posted for the surgery and anesthesia. Cardiac critical patients like Marfan syndrome versus the Williams syndrome. Here in Marfan syndrome, there is a FBN1. FBN1 is the issue, and that the threat is the aortic dissection. The goal is to minimize the wall stress. Management: beta blocker, avoid the hypertension and impulsive ejection fraction. So one should be very much careful while intubation. Pressure attenuation is a mandatory in this type of the patient. Williams syndrome, the threat is coronary ischemia and sudden cardiac arrest can be there. The goal is maintain the coronary perfusion. Management: avoid hypotension and tachycardia, because hypotension will decrease coronary perfusion and tachycardia also will reduce the coronary perfusion. In Marfan syndrome, the tension limit management, here the genetic FBN1 mutation, fibrillin 1 deficiency, and there is a dilatation of the aortic root. The threat is the wall stress. So key concept is the wall stress, critical threshold surgery. Surgery recommended when there is a more than 5 centimeter diameter of the root, and minimize the wall stress dp by dt with the beta blockers or ARBs. Surgical context, Bendel procedure or complete replacement, or the David procedure, valve sparing procedure. Marfan syndrome, connective tissue fragility, the genetic FBN1 mutation, weak connective tissue, the killer pathology, aortic root dilatation and dissection, and hemodynamic management. While Bendel surgery, one should keep the systolic blood pressure less than 120 millimeter Hg, prevent the wall shear stress, and the drugs used are, as I said, beta blocker, esmolol, to control the impulsive sudden increase in the blood pressure, and airway management. High arch palate can be there along with this, and temporomandibular junction laxity can be there in the patient, so difficult intubation can be there in this patient. Regional caution with the dural ectasia. So in a Williams syndrome, the hemodynamic manifest is the aortic root. There is a thickened elastin in the wall, and there is a supravalvular aortic stenosis. Aortic root may be dilated. Here, coronary osteostenosis and thickened root. They cause the coronary perfusion gap, mismatch of the coronary perfusion, risk of the sudden cardiac arrest 25 to 100%, and anesthetic mandate are the maintain the afterload or increase the afterload, maintain the preload, avoid the tachycardia, and these are critical for the aortic diastolic coronary filling. And coronary osteostenosis plus thickened root causes the coronary perfusion gap. This is the baby Williams syndrome faces in the young child. Not that the periorbital puffiness, fat nasal bridge, flat nasal bridge, and long philtrum, wide smile, full cheeks, and full lower lip. You can see the wide smile of the child with the full cheeks and full lower lip. Syndromic spotlight, Noonan syndrome. Clinical profile of the Noonan syndromes are rhizopathy, or often confused with the Turner syndrome, because these are the very similarity in this both this. Here patient is having the phenotype web neck, hypertelorism, low set ears, and a cardiac profile, pulmonary stenosis, most common 50 to 60%, and the hypertrophic cardiomyopathy 20% incidence is there in this Noonan syndrome. Hematological alert like a coagulation defect up to the 65%, factor deficiency can be there. Critical action, mandatory coagulation screening before regional anesthesia. So this patient bleed a lot. If you do the regional anesthesia and by chance some blood injury to the blood vessel, there is a hematoma chances are there. So be cautious and do this coagulation profile before proceeding for the regional anesthesia also, not only for the surgery but regional anesthesia also. Noonan syndrome, there is a problem with the flow and the clot. Flow problem is a cardiac problem, pulmonary subpulmonic stenosis, hypertrophic cardiomyopathy. Avoid the inotrope if dynamic obstruction exists. Then if we give the inotropic drug, it will increase the obstruction and the gradient increase. Another issue is with the Noonan syndrome is the clot, hematological bleeding diathesis, and 65% factor 11, 12, factor 8 deficiency, or the thrombocytopenia. Here, this is a typical features of the Noonan syndrome in a child. There is a inverted triangle shaped the head. You can see the inverted triangle shaped head, coarse facial features. Then there is a curly hair, wide forehead, and there is a neck skin webbing also there in this, and a small chin. You can see Pectus sternal deformity, prominent superior sternum and depressed inferior sternum. You can see in the second figure. Here there is a cubitus valgus and deformity of the upper extremity, angle at the elbow joint, and there is a widely spread nipples. Typical features of this Noonan syndrome. But Turner syndrome is for X chromosome abnormality is occur in the female, and Noonan syndrome can occur in any sex. So one also feature that differentiation can be there. Complex association, Charge syndrome. C stands for coloboma, H for heart defect, 75 to 80% of patients, like a TOF or AV canal defect, atresia coena, and 65% of the bilateral as a neonatal emergency, and retardation, mental retardation, growth or developmental delayed are there, genital hypoplasia, and ER abnormalities. Anesthesia alert, airway is the prime hazard. Corneal atresia, frequent tracheoesophageal fistula, post-operative airway events are frequent. So be careful while this type of the syndromic child is there. Difficulty in airway, and as the nowadays era of the transesophageal echocardiography, we are using mostly in all the patients transesophageal echocardiography. If we have to take the history of this baby immediately after birth, within 3 to 4 hours, if some surgery history is there, then we have to be careful about the operated case of the tracheoesophageal fistula, and one should avoid the transesophageal echocardiography because it can damage the esophagus. So here the airway architect, the airway is primary threat, and anticipate the difficult intubation, micrognathia plus corneal atresia, genetic note CHD7 gene mutation is there. Ear abnormality occur in the form of the deafness, retardation, mental retardation, growth retardation, and developmental delayed. And these patients are having atresia coena, means when there is a bilateral obstruction, they are obligate nasal breathing at risk. Complex association, vectoral association. V stands for vertebra, 70%, hemivertebra or the scoliosis. C stands for cardiac anomalies like VSD, 75%. A stands for analatresia, 55%. T stands for tracheoesophageal fistula, 32%. Risk of the gastric insufflation, and R is the, if a patient operated, then there is a chances of gastric insufflation, and of course, as we said, T is the problem. R stands for the renal, 50 to 80%. Avoid the nephrotoxic drug. L stands for limb. Here the problem is 70% radial dysplasia. 70% patient can have the radial dysplasia. So precaution, avoid neuroaxial block until spinal ultrasound rules out occult spinal dyspareunism and the tethered cord. Vectoral association, diagnosis and exclusion is a diagnosis of exclusion. Rather, when we exclude most of the syndrome, then we can have the diagnosis of the vectoral. We can assume that patient can have the vectoral. Here the diagnosis more than three features like vertebral, anal, cardiac, tracheoesophageal fistula, renal, and the limb. If a patient is having tracheoesophageal fistula, it has to be repaired in priority with ISI 3 to 4 hours. Ventilation strategy of the anesthetist to be, we have to ventilate, keep the tracheal lower border of the endotracheal tube above the just above the carina, below the fistula, to avoid the gastric distension. If our tube is placed above the fistula, then there is chances of gastric distension and the regurgitation chances are there. So we have to bypass this tract and we have to fix just above the carina to avoid these complications. Cardiac repair, complex cardiac defect may be required, some stage procedure also. And neuroaxial warning, ultrasound spine mandatory before planning for the regional anesthesia, because there is a tethered cord, chances are risk is there. The difficult airway and the spine matrix syndrome, trisomy 21 Down syndrome, macroglosia and subglottic stenosis, and atlantoaxial instability. So check the patient before proceeding. Williams syndrome, there is a cardiac lesion like hemodynamic collapse risk is more with the Williams syndrome. Pierre-Robin syndrome, micrognathia and glossoptosis, grade 3 to 4 view, and micro polysaccharidosis. Here the deposits or the obstruction is there in the airway, and there is a odontal hypoplasia can be there with the spinal cord, and Klippel-Frey syndrome or the Vector syndrome, fused vertebra, limited mobility. So we have to be careful for the spine as well as the airway. Synthesis, the perioperative checklist, preoperative genetic vascular cardiology consultant, echo definitive to define the shunt and the gradient, airway examination, Cooper score, and a congenital the coagulation profile has to be there before, because a patient in Noonan syndrome or cyanotic CHD, there are huge abnormality of the coagulation profile. Intraoperatively, difficult airway cart to be ready, maintains spontaneous ventilation. If high risk, this subacute bacterial endocarditis prophylaxis should be there. Define the hemodynamic goals before proceeding for the patients for the surgery. Post-operative multimodal pain management and the vigilance for the low cardiac output and PA crisis. ICU handoff should be careful. So conclusion, the circle of the safety, there is a unique coordination of the surgeon, anesthetist, perfusist and cardiologist. Start with the beginning of the pre-op assessment, hemodynamic stability, intraoperatively, perioperatively, surgical correction in the OT, and the post-operative vigilance, ICU care. All this leads to the successful outcome rely on the anticipating the pathophysiology of the defect and the systemic constraint of the syndrome. Conclusion and reference, successful management require navigating two antagonist physiology like shunt, PVR, SVR challenges, and anatomy, airway and the spine. The multidisciplinary approach is non-negotiable. So here the anesthesia challenges for the correction of the CHD, managing the difficult airway in the syndromic child, like safe anesthesia required, Noonan syndrome, Society of Pediatric Anesthesia, Marfan syndrome, Vectral charge syndrome, open anesthesia, and anesthetic consideration for the Williams syndrome. This is the PubMed article, and this article there is a use of the artificial intelligence for the few figures, and the major portion of this chapter, this is from the chapter of the Endopolis, congenital cardiac surgery and anesthesia. Thank you so much.